All right. So I'd like to begin with our acknowledgement of country. So North West Melbourne Primary Health Network and Western Health would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Next slide. So just the usual housekeeping, everybody is muted. Can you please ask your questions through the Q&A function? The session is being recorded and you will receive a link to the recording, copy of the slides and any additional resources that are discussed through the session. Next slide, please. So if you could please ensure that your name that you're coming up with on your screen is the name that you've registered with, and that way Yvonne will be able to mark off your attendance and ensure that you get your CPD points and your certificate of attendance. If you need to, then please send Yvonne a message and tell her who you are if you can't figure out how to change your name on your screen, because she doesn't know who Annie's iPhone is. So it gets a bit challenging for Yvonne. It's a bit late for her detective work. Next slide, please. So our session tonight is Endometriosis, the Hidden Pain, and there is some information on Health Pathways Melbourne on endometriosis. So next page, please. Slide. The Health Pathways provide clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines. The pathways are designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. The Health Pathways Melbourne is a collaborative program run by the Eastern Melbourne PHN and Northwest Melbourne PHN and is supported by local GPs, hospital specialists, health networks, community providers and other health professionals. And it's a short one-stop shop for clinical guidelines, medication information, referral information and further resources. Next slide, please. So the Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. Health Pathways Melbourne includes a comprehensive women's health suite that you can see there. It covers a wide range of important topics such as endometriosis, pelvic pain and other common women's health and complex conditions. It's all designed to support timely diagnosis, management and referral in general practice. Next slide, please. So there is a page dedicated to the endometriosis pathway and it's designed to assist clinicians in the assessment and management of both suspected and confirmed endometriosis, including cases diagnosed histologically via laparoscopy. The pathway provides step-by-step guidance on clinical assessment, including how to take a thorough history, key symptoms to look out for, and typical presentations. It also outlines best practice for abdominal and pelvic examinations, as well as recommended investigations. Each session includes expandable drop-downs with additional detail and context, making it a practical and comprehensive tool for clinicians managing patients with endometriosis in primary care. Next slide. So the management section of the endometriosis pathway provides clear clinical guidance based on the severity of the patient's symptoms. It also highlights the endometriosis and pelvic pain clinic, offering access to multidisciplinary care and support. The pathway links to non-acute gynecology referral options and outlines a statewide referral criteria, helping clinicians ensure appropriate and timely referrals. The referral section breaks down both acute and non-acute gynecology pathways, providing detailed instructions to streamline patient care and improve outcomes. Additionally, the information section for health professionals includes the latest endometriosis clinical practice guidelines supporting evidence-based decision-making in primary care. Next slide, please. So this slide provides a list of the relevant and related pathways and resources for endometriosis. So lots of information there for us GPs. Next slide, please. So you may not be aware that Health Pathways is a tool that can help you with reflective learning that contributes to CPD hours. So you can earn your CPD while using the pathways. You now have access to the CPD reporting feature there on the right, and this can be accessed through the secondary panel on the right hand side corner. The CPD reporting function allows users to use the platform to record and report continuous professional development activities, collate all CPD activities across multiple categories into a single report, add reflections, learning notes, and descriptions of practice improvements. For both the RACGP and ACRM, you need to complete 30 minutes each of a performance review and educational activity to log it. After completing these, enter the details into the reflective activity template and submit them online with the links or via your MyCPD app. Next slide, please. So if you don't have access to Health Pathways, you can register via by sending an email to the team or by scanning the QR code, and it'll take you through. So we all used to have a kind of generic login. There is now individual logins, so please don't share them with other people. And if you've got any queries about the pathways, then please contact the Health Pathways team. Each pathway has a feedback section, so if you've wanted some extra information or had some queries, you can go through that as well. All right, so next slide, please. So our speakers tonight, we have two wonderful speakers. First is Dr. Samina Ahmed. Samina has specialty appointments as a specialist obstetrician and gynaecologist at the Joan Kerner Women's and Children's Hospital, at North Park Private Hospital and St Vincent's Private Hospital. She also holds a subspecialty appointments in fertility at Joan Kerner. And in this role, she assists couples to produce offspring through assisted reproductive techniques. She's an active member of the Fertility Society of Australia and New Zealand, Australasian Gynaecology, Endoscopy and Surgery Society, and the Australian Society for Colposcopy and Cervical Pathology. She actively engages in ongoing activities to provide evidence-based advanced care to her patients. In addition, Samina holds senior academic appointments at Deakin Uni and at the University of Melbourne. She is also a training supervisor at the Royal College of Obstetricians and Gynaecologists. Is also making time for us to update us this evening. So thank you, Samina. Our other speaker is Ranjana Raman. Ranjana is a passionate women's health physiotherapist at Western Specialist Centre in Werribee. She's expertise in pelvic floor therapy, birth trauma recovery, and managing conditions like endometriosis, PCOS, and bowel health. Ranjana is dedicated to empowering women, especially from multicultural and migrant backgrounds, through education and compassionate care. Her community outreach involves workshops and speaking engagements with organisations such as the Australian Multicultural Women's Association and the Australian Islamic Medical Association. Ranjana's mission is to break down health stigmas and improving access to women's health services for all. So thank you, Ranjana, for giving up your time today. So I'll now hand over to Samina for her presentation.
All right. Thank you very much, Yvonne and Joe, for your kind introduction, and welcome everyone. This evening, we are going to discuss endometriosis and try to unveil the challenges and advancements in management. I hope you are keeping yourself warm in this crazy weather, and we will go through these challenges together this evening. So, now, this presentation provides a comprehensive view of endometriosis, and topics include this evening, basically the prevalence, societal cost, and the science behind its pathophysiology, typical symptoms experienced by these patients, diagnosis techniques, both invasive and non-invasive. We will also discuss the medical and surgical treatment options available, try to highlight the RANSCOG 2025 guidelines and understand the role of multidisciplinary care in the management of these patients. I would also explore endometriosis links with other inflammatory conditions, review the recent policy updates in Australia. I will also present some real-life case studies towards the end of my presentation, and will share some support services which are available for these affected individuals in Australia. So as far as endometriosis is concerned, it's far more than just painful period. It's a chronic, often progressive inflammatory condition with a systemic impact. What sets it apart is that endometrial-like tissue grows in places it shouldn't, on ovaries, fallopian tubes, bowel, bladder, and even distant organs. These implants respond to hormonal cycles, breaking down and bleeding internally, which can cause intense pelvic pain, formation of adhesions leading to the formation of scar tissue, complications like bowel, bladder dysfunction, and significant fertility challenges. According to the statistics, Australian women and individuals assigned female at birth before menopause can suffer significantly from this condition. And the individuals' number can go up to 1 in 9. Despite this high prevalence, awareness remains low, leading to delays in diagnosis and care. RANSCOG and Endometriosis Australia both emphasize early recognition and access to care as critical to improving the outcomes for these patients. Now, we will start by looking at the scale of endometriosis and its impact on Australian society. As far as the economic burden is considered, it costs the Australian economy over 9.7 billion annually. This includes direct healthcare costs, but more significantly, it reflects the indirect cost like lost work productivity, absence from work due to pain and fatigue. Diagnostic delay is actually something which is very significant for these patients. According to the statistics, the diagnosis delay ranges between 6 to 8 years. This is due to a combination of factors such as normalization of symptoms from patient's perspective or from the healthcare providers, stigma attached, lack of awareness, and delays in referrals. These figures, which I have shared here, highlight why early recognition, education, and healthcare system reforms are critical in reducing the burden of this disease. Now, it's very important for us to understand as professionals what is happening inside our body or patient's body at a biological level when an individual develops endometriosis. As we all know, there are several leading theories explaining how endometrial-like tissue ends up outside the uterus. The most popular one is the retrograde menstruation theory. It proposes that menstrual blood flow backwards through the fallopian tubes into the pelvic cavity instead of leaving the body, allowing endometrial cell to implant on other organs. The next popular theory is coelomic metaplasia, which suggests that cells lining the pelvic cavity can transform into endometrial-like cells under certain hormonal or environmental influences. The third theory, which has become really popular over the period of time, is immune dysfunction. That stray endometrial-like cells, and in patients who have this dysfunction, there is a possibility that the immune system is unable to get rid of these endometrial-like cells and as a result of which, allowing them to implant and proliferate. And there's another theory which is being linked, which is called stem cell theory. And the recent evidence indicates that stem cells from bone marrow or the endometrium might migrate and contribute to lesion formation. Now, once all these ectopic cells implantation happening, what happened that these ectopic implants respond to estrogen, driving growth and inflammation, produce pro-inflammatory cytokines, creating a chronic inflammatory environment. They also undergo new blood vessel formation, which is called endogenesis, which is important for their survival. Interacting with the close by nerve fibers, they can lead to neuropathic pain and central sensitization, leading to chronic pelvic pain or chronic pain syndrome. This complex pathophysiology explains why endometriosis is more than just misplaced tissue. It is a multifactorial systemic disease involving hormonal, immunological, and neurological components, as we can see here in this flow chart. Now, here I would like to discuss the symptoms which are associated with endometriosis. When we are discussing symptoms, it's important to emphasize the broad spectrum of clinical presentation. Not every patient experiences the same symptoms or intensity. The most common symptom is dysmenorrhea. Unlike normal period pain, endometriosis-associated dysmenorrhea tends to worsen over time and may not respond well to conventional pain relief therapies. Pain can occur at any time, not just during menstruation. It may become debilitating, significantly impacting daily activities and quality of life, resulting in chronic pelvic pain syndrome. Now, painful intercourse is a quite common and underreported symptom, frequently due to deep infiltrating endometriosis involving pelvic nerves and ligaments. Now, endometriosis can interfere with ovulation, tubal function, and uterine receptivity. And up to 30 to 50% of women with endometriosis may struggle with fertility issues. Bladder and bowel dysfunction is quite frequent in these patients. This includes painful defecation, bloating, urinary urgency, and in some cases, blood in stool and urine. These symptoms often lead to misdiagnosis such as irritable bowel syndrome or urinary tract infections. It's very important to understand that symptom severity does not always correlate with disease extent. Some women with minimal disease have severe symptoms, while others with extensive lesions may be asymptomatic. The aim is to increase awareness among both clinicians and patients. Early recognition of these symptoms is key to timely diagnosis and intervention. Diagnosis endometriosis remains a complex process due to the variability in symptoms and the limitations of current diagnostic tools. Thankfully, Endometriosis Australia and RANSCOG have highlighted pathways for the early recognition and diagnosis of endometriosis. The diagnostic journey begins with a detailed patient's history. We need to explore pain during menstruation, intercourse, bowel and bladder habits, fatigue, and infertility. Symptoms scoring tools like visual analog scales or validated questionnaires help standardize assessments. Imaging techniques like pelvic ultrasound and MRI can detect some forms of endometriosis, such as endometriomas, deep infiltrating lesions, etc. However, imaging is operator dependent And there's a possibility that superficial peritoneal disease may not be visible. MRI may offer better visualization of deep pelvic structures in specialized centers. As far as laparoscopy is concerned, it is still the gold standard. Laparoscopy allows for direct visualization and histological confirmation. It also provides the opportunity to surgically treat lesions. However, due to its invasive nature, many guidelines now advocate for a clinical diagnosis first, especially when symptoms are classical and imaging is suggested. Evolving practices are suggesting under the guidance of 2024 RANSCOG guidelines and ISHA 2022 update, that early clinical diagnosis and treatment initiation without necessarily waiting for surgical confirmation. Now, this actually reduces the diagnostic delay and enables clinicians to manage patients' symptoms as early as possible to improve their quality of life. We must also educate primary care providers and specialists to consider endometriosis early and use available tools efficiently. A visual diagnostic flowchart can support decision-making, particularly when to refer for imaging or specialist care. In my upcoming slide, I will discuss the different stages of endometriosis, which will be highly beneficial for the audience here. So maybe most of you are already aware of that endometriosis is divided into 4 stages. Stage 1 is minimal endometriosis, where we actually find endometrial implants or on peritoneum only. Stage 2 is more invasive disease with the possibility of some deeper scar tissue. In stage 3, we find many deep endometrial implants and cysts involving at least one ovary, and flimsy adhesions may be present. In stage 4, we have the severe form of this disease. Many cysts and large adhesions are present, and they may require more than one kind of treatment and multiple surgeries. I'm sure that you might have heard about this new assessment tool, which is called RATE, which we have introduced into the patient care now. So the RATE tool is a practical and patient-centered framework, which is developed by the Pelvic Pain Foundation of Australia to help primary care clinicians and specialists assess and manage persistent pelvic pain, including endometriosis. Now, what RATE stands for? So RATE is an acronym that stands for recognition, assessment, tracking, and evaluation. So what we are trying to recognize here? We are trying to recognize symptoms of pelvic pain as early as possible. This includes not only period pain, but also bladder, bowel, sexual, and musculoskeletal pain. It also includes fatigue-related symptoms. Recognition should be guided by clinical suspicion, especially in patients who have experienced persistent pain since adolescence or whose symptoms are affecting their school, work, or relationships. Now, the assessment involved the impact of pain holistically. Where is the pain? When does it occur? Example, cyclically or acyclically? What body symptoms are involved? What has already been tried? Pain drawings, visual analog scales, or menstrual symptom diaries can help track severity and changes over the period of time. As far as tracking is concerned, we are tracking here symptoms and treatment responses using simple tools. These include apps, calendars, or regular check-ins. Tracking allows patients to visualize their journey and help clinicians adjust management based on real-world outcomes. Coming towards evaluation. It's very important to evaluate the need for a multidisciplinary approach, referrals, or a change in diagnosis or treatment. If symptoms are complex, involve other professionals like pelvic physiotherapists, psychologists, dietitians, or gynecologists. So in summary, what RATE tool is doing? RATE tool is actually encouraging early recognition and proactive care, moving away from the traditional wait and see approach. It is particularly useful for primary care providers, school health professionals, and clinicians working in regional or resource-limiting settings. It empowers shared decision-making and keeps the patient actively involved in their care. So when it comes to managing endometriosis, adopting a patient-centered care model is essential, not just recommended. This means involving the patient in every stage of their diagnosis and treatment journey. We must move away from a paternalistic approach or model of care, and instead we need to foster an environment where patients are empowered partners. Whether it's choosing between hormonal therapies, surgical options, or lifestyle modifications, patients should be presented with clear, evidence-based choices, including the risk, benefits, and alternatives. It's very important that we respect their values, needs, and preferences. As I said earlier, endometriosis does not impact everyone the same way. For some, pain is the most pressing issue. For others, it's fertility, work-life disruptions, or emotional well-being. So it's important to ask what matters most to you. This allows us to tailor management plans that align with the patient's life goals and cultural context and treatment tolerance. As far as education and management engagement is concerned, informed patients are making better decisions for themselves. Education is not just about handing them over leaflets. It's about ongoing dialogues, using accessible language, and credible resources, providing them information regarding online platforms which are available, support groups, and care coordinators. This enhances adherence and ensures patients feel supported throughout their journey. Ultimately, the goal of patient-centered care is to improve treatment satisfaction, emotional outcomes, and likely clinical results. The 2025 RANSCOG guidelines strongly reinforce this approach as a standard of care. So now I will start the medical and surgical management of these patients. As far as medical management options are concerned, we have got first-line popular management option available, which are in the form of NSAIDs and combined oral contraceptive pills. The second line is progestogen, which includes oral, IUD, or implant. The third line management options are GnRH analogs and SPRMs. And the newer agents which are now available in Australia on PBS list are Ryco, Vizane, and Slinda. Now, in this slide, I will focus more on the newer agent, which is SPRM. Now, SPRM is a selective progesterone receptor modulator. They are newer class of hormonal agents, increasingly being used in the management of endometriosis over the past couple of years, especially since 2022. SPRMs are unique because they are selectively binding to progesterone receptors and act in a dual manner, depending on the tissue they are working on. In some tissue, they act as agonist, meaning that they stimulate progesterone activity. In other tissue, they act as antagonist, blocking progesterone's effect. Now, what this dual action is achieving? This selective action allows SPRM to exert targeted therapeutic effects while minimizing systemic side effects seen with other hormonal treatments. For example, in endometrial tissue outside the uterus, SPRM can help suppress inflammation, reduce lesion size, and reduction in pain. Yet in other tissues, they may preserve beneficial hormonal activity. So the widely used SPRM currently is Danochest, which with brand name of Visane, which has shown strong evidence in reducing pain scores and lesion progression in endometriosis. Another agent which is in use, it's ulipristal acetate, although its use is more established in fibroid management. So SPRM do not cause a hypoestrogenic state like GnRH analog, so they are often better tolerated and don't require adjunct therapy. Ongoing research continues to refine how and where SPRMs can be optimally applied in chronic gynecological conditions like endometriosis. Now, in this slide, I would like to discuss another new endometriosis medicine, which is available in Australia on PBS listing now, and that is called Ryco. Ryco is showing significant promise in the treatment of endometriosis. While it's not SPRM by definition, it mimics many of the clinical benefits of SPRM. So making it really valuable new generation option for patients seeking effective symptom relief with better tolerance. Now, the question would be, what is Ryco in first place? So this is a combined oral contraceptive pill, which includes 3 agents. The first one is a GnRH antagonist, which is called relugolix, that suppress ovarian hormone production. The second agent is estradiol, which is required to maintain baseline estrogen level and prevent hypoestrogenic symptoms like bone loss that can result from GnRH antagonist. The third agent is a progestogen, norethistron acetate, which is required for endometrial protection and contributes to simple symptom control. Now, what is the action of Ryco or this medication? So these 3 agents effectively reduces estrogen to low physiological levels, which helps to suppress ectopic endometrial tissue activity, resulting in the reduction of chronic pelvic pain and dyspareunia. It also minimizes the need for surgical intervention in selected cases. Unlike older GnRH agonists, relugolix works faster, does not cause an initial flare of symptoms, and is taken orally once daily, offering convenience and high patient adherence. Now, when I'm suggesting that these newer agents are PBS listed, why it is significant? It is significant because this PBS listing has enabled patients to access the affordable long-term treatment. Patients benefit from cost saving, and this saving can sometimes go beyond $400 per year compared to non-subsidized options. Overall, Ryco bridges the gap between efficacy and tolerance, providing SPRM-like benefits without the full side effects profile of traditional hormonal therapies. It is particularly useful for patients who have failed or can't tolerate other treatments. In my upcoming slides, I would like to share with you the comparison of all these newer medications. So here you can see that Ryco is a combo SPRM. Cost saving are high and associated with high effectiveness. The side effects are nausea and vomiting. Visane is a progestogen. It is associated with moderate cost saving, quite effective, and is associated with mood changes. Celinda has been in use as well. It is a progestogen. Cost saving are moderate, Effectiveness is moderate and side effects are minimal. Now, what is important while a patient is on any of the medical treatment? It's very important that we monitor the duration and response. Regular reviews every 6 to 12 months are required for these patients. Maximum duration for GnRH analog is 6 to 12 months. SPRMs may be continued longer if tolerated well. As far as RICO is concerned, we need DEXA monitoring or bone mineral density monitoring for these patients, and we don't have longer of data available for more than 2 years regarding RICO use. So if a patient has good symptom control and they want to continue beyond 2 years, that decision needs to be taken mutually by the patient and the clinician. Now, this is a flow chart just showing that how the recent PBS and Medicare changes of these medications, which includes RICO, Slinda, and Mezine, has improved the cost savings for the patient. As most of you are aware of, that now we have got MBS item numbers for long consults for both GPs and specialists, and which is contributing significantly in cost savings for our patients. In the upcoming slide, I will discuss the surgical management for patients suffering with endometriosis. So as I said earlier, laparoscopy remains the gold standard. This minimally invasive procedure allows both diagnosis and treatment. Visualization during laparoscopy helps stage the disease and identify atypical lesions not seen on imaging. Surgical options include excision and ablation. I come across a lot of questions related to excision versus ablation. So I just thought to clarify a few things about both techniques. As far as excision is concerned, it involves cutting out the lesion, including deeper nodules and endometriomas. Ablation actually involves heat or energy to destroy surface lesion, but it can miss deeper disease. So excision is often favored for its low recurrence case, especially in cases of deep infiltrating endometriosis. Now, studies have suggested that surgery can significantly reduce pain, especially dysmenorrhea and dyspareunia. For fertility patients, surgical removal of stage 1 to 2 disease improves spontaneous conception rate, whereas in patients who are suffering with advanced stages 3 or to 4, combined surgery with ART treatment yields better results. One thing I am trying to emphasize again and again is multidisciplinary approach, which plays a vital role in the management of these patients. As far as the multidisciplinary team is considered, a combination of gynecologists, colorectal, and urological surgeons, particularly for deep infiltrating or extrapelvic disease, ensure better treatment outcome. RANSCOG 2025 and 2022 ISHR guidelines have recommended surgery for patients who have not responded to medical therapy, patients who have endometriomas greater than 3 centimeters, have bowel or bladder involvement, and are trying to conceive but are facing barriers. As far as the recurrence is considered, unfortunately, a recurrence occurs in up to 40 to 50% of patients within 5 years if hormonal suppression is not continued post-surgery. Therefore, surgical treatment should be integrated with medical management, especially for long-term symptom control. In my upcoming slide, I will discuss the role of surgery in fertility preservation. As far as early surgical referral for moderate to severe endo is considered, we have evidence that ART plus surgery is associated with best outcomes. RANSCOG guidelines, which are being released in 2025, it emphasizes on non-invasive diagnostic techniques, early medical interventions, recognition of extrapelvic symptoms, and emphasizes on holistic lifelong management. Now, in these upcoming slides, I will discuss the overlap between endometriosis and other inflammatory conditions, as a lot of evidence now coming up, which is suggesting that endometriosis is not just a gynecological condition. It's actually a systemic inflammatory disease with broad immunologic and metabolic implications. The evidence is suggesting that endometriosis shares chronic inflammatory pathways with several other conditions, leading to elevated pro-inflammatory cytokines, altered macrophages and T cell function, increased oxidative stress and angiogenesis, which is the new vessel formation. And all of these changes come together, leading to systemic inflammation, which explains why many patients report widespread symptoms, pain and fatigue, not just pelvic pain. Studies have also identified significantly high rates of associated conditions in these patients. And these conditions are irritable bowel syndrome, interstitial cystitis, popularly known as bladder pain syndrome, autoimmune disorders such as Hashimoto's thyroiditis, arthritis, SLE, chronic fatigue syndrome, and fibromyalgia. Now, what is the clinical relevance? The overlap of all these conditions can delay diagnosis due to misattribution of different symptoms. This can complicate treatment. It can increase mental health burden. And that's why it's very important to have a multidisciplinary team on board, including gastroenterologists, immunologists, pain specialists, and psychologists. In the upcoming slide, I'm going to share a few real-life examples where we actually applied all these examples or all these references I have just shared with you in the management of the patient care. And we actually managed to achieve few outcomes, good outcomes. So the first real-life example is regarding patient-centered care. So we had a patient, Sarah, who presented with severe dysmenorrhea. She had chronic pelvic pain, and she was having difficulty in falling pregnant. She has seen multiple GPs over the years and was initially prescribed the oral contraceptive pill. However, she discontinued it due to mood-related side effects. After being referred to specialists, Sarah was diagnosed with stage 3 endometriosis by laparoscopy. She expressed concern about starting another hormonal treatment due to the past experience, but also feel anxious about her fertility window narrowing. So in Sarah, we applied a patient-centered approach where we listened to her concern about hormonal therapies and emotional well-being. We discussed different medical options such as progesterone-only pills like Slinda, Mirena, or Visane, explaining benefits and potential side effects. We introduced surgical options and explore whether excision might improve pain and fertility outcome for Sarah. We also involved a fertility specialist to map out timelines for trying to conceive. We referred her to a pelvic physiotherapist and a psychologist to address pain and anxiety. We provided her educational resources and connected her with Endometriosis Australia's support network. Together, we co-designed a treatment plan that aligns with Sarah's needs, respecting her values, balancing symptoms relief, emotional health, and fertility preservation. Over time, Sarah started reporting reduced pain, and eventually she ended up conceiving through IVF. Now, the next case study is the management of complex pelvic pain in one of our patients. So this is regarding Linda, who is 32 years old, and she presented with 8 years history of symptoms suggesting endometriosis and adenomyosis. She had multiple GP visits and she was misdiagnosed as IBS. Finally, using the help of visual scoring chart and symptoms, we diagnosed her by laparoscopy with stage 2 endometriosis. She was managed with Visane, physio, and diet changes. Our next study is case study is regarding the fertility journey of a young patient. So this patient was 28 years old with stage 3 endometriosis. She underwent excision surgery for endometriosis with multidisciplinary team involving gynecologist and colorectal surgeon, and she managed to conceive by IVF 12 months later. In this slide, I have shared with my audience some support services which are available in Australia and are providing great support to these patients. This includes Endometriosis Australia, Jean Hills Foundation, Pelvic Pain Foundation Victoria, EndoActive, local hospital endo centers. And obviously, we have got visual support logos and contact lines. To conclude, I would like to say that endometriosis remains one of the most underdiagnosed and misunderstood chronic conditions affecting reproductive age individuals. Clinicians must prioritize early intervention, advocate for patient-centered and multidisciplinary care, and remain informed on the latest evidence and resources available. Continued education and collaboration are critical in reshaping the endometriosis care landscape. Chronic, often misdiagnosed condition with high burden on the economy. Role of education, collaboration, and advocacy. While we know that the burden is immense, evolving guidelines and healthcare reforms offer hope for earlier diagnosis, improve access to treatment, and a better quality of life. Importance of early diagnosis and holistic care is the key for managing these patients. In the presence of new guidelines and MBS, PBS changes, we have now better access to utilize these resources. Thank you very much for your attention. And I would like to hand over the session now to Ranjana Rahman, who is a valued pelvic physiotherapist in the area. Joe, you want to say something?
I've just got a question, Samina, before we hand over to Ranjana. A question here is Riago also restricted to 6 to 12 month treatment length?
No, that's not right. So as far as we are talking about RICO, isn't it?
Mm.
So RICO is not restricted to 6 to 12 months. 6 to 12 months is GnRH analogs like Zoladex, etc. As far as RICO is concerned, we don't have data available for longer than 2 years. As far as the RICO manufacturer's guideline are concerned, we can obviously commence it to the patient with some baseline DEXA scanning. They need regular follow-up 6 to 12 months. They need yearly DEXA scanning. But after 2 years of use, as the data is not available, that should be a mutual decision between the clinician and the patient whether they want to continue RICO for their symptom control or not.
Okay. So would you do a baseline DEXA and then repeat it at the 2-year mark?
Yearly. So we do a baseline DEXA and then yearly. So if we have done first one within first 6 months of the commencement of treatment, then that would be enough for that year, I would say, and then you will require one more at the end of 2 years. But after that, it is mutual decision. At this stage, we don't have longer data available beyond 2 years.
Mm. Okay.
Yeah. And I would suggest my GP colleagues that if they are struggling, they should refer patients for discussion to a specialist.
Yeah. And Rago, is it for specialists to commence? GPs can't commence it, is that correct?
You see, as far as the RICO manufacturers are they actually are suggesting that GPs can commence it, but you need visual diagnosis for that, like either laparoscopically or ultrasound suggesting endometriosis.
Okay.
So, I would say considering the side effect profile and long-term management, if GPs are happy to follow all that, maybe they can do it. But I would suggest on this forum that it should be initiated by gynecologist. And if this required symptom response is achieved, they can be discharged back to the GPs for further monitoring, like symptom regulation, DEXA monitoring. And then maybe at the 2 years, if the guidelines remain same, if we don't have too long-term data available, then they can refer the patient back to the specialist for further discussion regarding ongoing treatment.
Yeah. And do you know if the PBS is restricted to specialist commencement? Because some of those newer medications is specialist commencement and GPs can then continue.
No, I don't think so, that it is restricted to specialist only. I think that listing can be utilized by GPs too.
Okay, great.
Because we are discharging patients back to, after 6 months of commencement of treatment, we discharge them back to GPs.
Okay. Okay. Thank you.
With pleasure.
Thanks, Ranjana. We can see your slides now.
Hello, everyone. My name is Ranjana. I'm a women's health and peds physio working from Werribee. Joe's gone through my introduction, so I'll get through my presentation for tonight. So I am going to speak about pelvic health and predominantly pelvic pain, a physiotherapy management of pelvic pain, what that includes and how we go about. Just a minute, I've done something. All right.
It looks like your internet might be slowing you down, Ranjana. Maybe if you switched your camera off.
6 goes on today's
Looks like Ranjana's having some internet problems tonight.
Ranjana's screen is frozen, I believe. Let me just call her.
now.
Are you still there, Ranjana?
I think she's dropped off, Yvonne.
Yep, sounds like she's frozen.
Yeah, she's frozen. Are you just giving her a call?
Great. Thanks, Amina.
Yes,
Have you sorted out everybody, Yvonne? Anybody else you need to remind that we need to chase up while we're all online?
We do. I have sent, if everyone can check their chats, I have sent a couple people some reminders because they have entered with iPhone or some names that I haven't actually got on the register. So they can everyone can check their chats, and if they've received a message from me, I'd be delighted if you can respond to me so I can make sure I send off your certificates for attending tonight and your CPD hours as well.
Can you hear me now?
Ranjana, we can hear you now.
Yeah.
Great.
I don't know if there's some issue with the internet.
Yes, I know you were doing so well. And then as soon as you went to speak. So your slide's back on now, if you pop it into presentation mode. There we go. We do see the top of your browser though, that's all.
Yeah.
Amazing. Yep, great. You're at introduction, the introduction slide.
Yes. So sorry for the delay. Today's presentation, I'll be talking about the nature of the pelvic pain, its causes, and how physiotherapy plays a vital role in managing, treating, and supporting women who experience persistent pelvic pain. Like how Dr. Samina said, they have it's a big impact on the Medicare, and women who have this kind of pain would also be taking a couple of days off work, impacts their work, impacts their mental health, impacts their relationship with others. So it's how we are helping them manage this pain and move forward. So the pain interferes with their daily life, causing difficulty with mobility, work, and social activities. It also, when someone has persistent pelvic pain, it leads to depression, anxiety, and low quality of life. Sexually, it affects intimacy and relationship with their partners. And pelvic pain could be interconnected with different systems and requires a comprehensive approach to treatment. So how does physiotherapy play an important role in managing pelvic pain? So physiotherapy is essential because as physios, we look at the musculoskeletal system, how can that improve the patient's mobility, how can it reduce pain, and how can also it enhance their quality of life. So our primary goal is reducing pain, inflammation, improving pelvic floor function, enhancing strength, flexibility, coordination, and also managing stress, and providing them with strategies which they can use when there is a flare-up. So first thing is pelvic floor muscle training. So a lot of, so whenever a woman who has a chronic pelvic pain, they go on to internet and they start doing Kegels exercises. But in a way, that is actually making things go worse because a lot of these women have some kind of a dysfunction in their muscle function. So they have a lot of tightness and weakness. I don't know, it's two different things. Like your pelvic floor is tight and weak at the same time. So when the pelvic floor is tight and you start using your pelvic floor exercises, you're only recruiting few of the muscles which are not hypertonic, and the ones which are hypertonic, you're increasing the stiffness in them. So the first line of action whenever we get a pelvic pain patient is to first downtrain these pelvic floor muscle. Downtrain is reducing their overactivity because pelvic floor muscles have attachments abdominally, and it also attaches onto the lower back. So the pelvic floor forms the base and it has attachments at the front and at the back. So a woman could have a very hypertonic pelvic floor and could suffer from severe low back pain. And they've had normal imaging done, they've had physio sessions for their low back, but the pain has never gone. It's actually a referred pain coming from their pelvic floor. In the other case, a woman might have a lot of abdominal pain and they've had investigations done and we could never ascertain what's the cause. But when you actually go and have a look at their pelvic floor, they are on the hypertonic end because of the muscles, how they attach. It's very important to first start with down training. So the first line of action is we look at the tightness, we look how weak they are, how is the coordination of the pelvic floor muscles, and especially when we load it with your everyday activities, how the pain goes. So are these women getting pain end of the day when they are very tired, or how are they getting it first thing in the morning? That gives us an idea whether there is any pelvic floor dysfunction. Once we find that if there is a pelvic floor dysfunction, these pelvic floor dysfunction can lead to a lot of these myofascial pelvic pain, urinary issue, and sexual pain. So if the pelvic floor muscles are tighter, it's very hard to get a penetration because they are like that rigid. They're not ready to let go. The other thing is the normal anatomy and the normal physiology of these pelvic floor muscles are to keep a woman continent, support the pelvic floor organs, and also to help with sexual function. Now, few of these fibers are tighter, I would say hypertonic, and they are in spasm. They're not going to work very well to close the urethra. And a lot of these women would get incontinence. So the moment you go and downtrain their pelvic floor muscles, they become continent again because the muscle starts working back to its normal function of keeping a woman continent. So the first approach always has to be for someone who has pain after they've had an assessment is to involve a lot of downtraining and relaxing the tight pelvic muscles. Strengthening. So once these muscles have relaxed, they come back to their normal tone, then we target, because they are like I said at the start, they are tight and weak at the same end because they have been tight for so long and they've been holding that spasticity for so long, they are also weaker. So after they have downtrained and the tone has gone back to normal, we then look at strengthening. So what is myofascial pelvic pain? Myofascial pelvic pain is a chronic pelvic pain characterized by myofascial trigger points within the pelvic floor musculature. So we've got the levator ani and we've got the coccygeus. So these are the two muscles. If there are trigger spots, they can reflect pain to your lower back and also to the abdominal. So how do we do it is we release these points. And the best way we do it is hands-on. So we go in vaginally, we find these spots, and then we work on these fascias to relieve the pain. The other thing is we also use biofeedback. So the biofeedback gives the women an idea, because a lot of times these women don't understand that they are clenching onto their muscle rather than relaxing. So it's getting them to actually feel that, they are clenching rather than, the pelvic floor muscle tone is normal. The other thing is electric stimulation, which helps to reduce tightness and improve function. These are the three ways we downtrain the pelvic floor muscle, and a lot of feedback. So a feedback in the sense, a lot of, I'll go through that in my next slides. How do we make a woman realize they are actually clenching it rather than, keeping it in a normal tone? Hope I'm not going too fast. Now, exercise and movement in pelvic pain. So it's gold standard that anyone who has pelvic pain is given some sort of aerobic exercises to do most days of the week. Exercises has its own benefit. It helps reduce pain and overall health. So even a 30-minute of gentle walking has shown to improve the pain levels, because when you're walking, these muscles, they stretch, the hip mobility improves because of the way these muscles are attached. The hip mobility improves, and that brings about more, so rather than some muscles which is very tight and crunched up, when you're walking and when you're doing gentle exercises, they get a stretch, and that helps improve their mobility. Other thing specifically for pelvic pain, which works very well, is Pilates and yoga. Gentle exercises like yoga have shown to alleviate pain. So what yoga does is yoga uses a lot of breathing and a lot of relaxation. So whenever these women are doing a lot of strength training, we potentially tell them to stop strength training till their pelvic pain reduces, because whenever they do strength training, they are creating that Valsalva maneuver from within, which is they are like, clenching in more to generate the strength to lift heavy weights. When that sort of a clenching happens, the tone in the pelvic floor increases. So right now we are trying to reduce the pelvic tone, and they are doing exercises which is increasing. So we tell them to stop or change resistance training into Pilates and more yoga, where a lot of breathing is involved, so that they get that stretch happening through the pelvic floor. Other thing is pelvic floor exercises. So pelvic floor exercises where we look at relaxation. So we don't even start Kegels. We don't even start any strengthening until the pain comes down. Only when the pain comes down, we'll look at strengthening. If we start strengthening straight away, it's going to make their symptoms go even worse. Other thing very important is stress reduction and mindfulness. So mental health and pelvic pain. Stress and anxiety can exacerbate the pelvic pain. So managing mental health is crucial in the treatment. Now, how stress and anxiety is connected to pelvic floor? As like all of us, we do get stress from time to time in our day-to-day life. Some of us clench our jaw, some of us clench our trapezius, and we have that, upper neck pain. So the women who have a lot of pelvic pain issue, they are the ones who clench their pelvic floor. So anytime there is a stressful condition or they are anxious, they start clenching onto their pelvic floor, and that causes a lot of increase in their pelvic floor tone. So we are So once you start making them aware that there is a connection between stress and anxiety and their pelvic floor, they are able to then connect that link. And whenever they get stressed, they then focus on their deep breathing rather than clenching. Other physiotherapy techniques include mindfulness and breathing exercises. So teaching them deep breathing exercises and meditation will help manage their stress and pain levels. So we teach them this so that whenever they are in a stressful situation, they can work on their deep breathing exercises and relax their pelvic tone rather than clenching it. Coping strategies, learning them how to cope with flare-up, manage their pain day to day is the key. So, telling them if there is a flare up, you look at, doing a lot of deep breathing exercises, you do stretches, you do the butterfly stretches, you use some heat packs, and you manage your stress levels, try and bring down the pain. That's how we teach them. So that we are self-equipping them whenever there is small flare up so that they can manage their symptoms. And adequate sleep and rest. Ensuring adequate sleep and good sleep hygiene is vital for healing and managing persistent pain. So 7 to 8 hours of good sleep, regular walking, deep breathing exercises have shown to improve their pain levels quite significantly. Now, other innovative therapies in pelvic pain management is using the TENS. So the TENS is a transcutaneous electric nerve stimulation. It's like a small box, small machine, and it comes with 4 electrodes, and we predominantly use it to stimulate the posterior tibial nerve. So the posterior tibial nerve comes very superficial on the medial side of your leg, near your medial malleolus. So we ask them to place it there 30 minutes, and it's a 12-week program, which they do it for most days, 5 to 6 days in a day. It runs for 30 minutes on the probe, and that helps with bringing down the pain. Other thing is physical activity and chronic pain. We give them a regular, so everyone has a set of exercises they do. Regular physical activity has shown to reduce the severity of chronic pelvic pain and improve overall physical function. Exercises can also impact dysmenorrhea and other pelvic pain. Am I going too fast, or is there any questions, or should I keep going, or do we do questions at?
We'll do questions at the end, Ranyana, unless there's something pressing, then I'll interrupt you. But no, you're doing really well. So thank you.
All right. Next is flare-up management and pain relief. So pain flare-up, it's very common that, sometimes patients who have chronic pelvic pain will experience flare-up, and we can never say when that flare-up would be. It could be sometimes they were a bit constipated, and that's increased the tension in the pelvic. They were pushing, and that caused increase in the pelvic floor tension. Or if they've had a very stressful day and it's been going on for a few days, and that's caused a flare-up. Or there has been some sort of a injury, they've had a fall, they've had any fractures. So flare-up could happen anytime, and it could be also during the period time, like and then the pain has flared up. So what we do is we teach them to use heat therapy, gentle stretches, which is normally a butterfly stretches, and mindful breathing can help manage flare-up. So when they have these tools on their hand, they are able to address their symptoms much better. Educating them how to manage their pain at home is essential for empowering patients. So, giving them that power as well helps, because they know that, if I have a little bit, it's not that if I have a little bit flare, I have to run and come back to my physio, go to the doctor. They are like, okay, let me try this, let me try that way, and, see how I go. And any sort of a pelvic pain, I think the gold standard is to work in a multidisciplinary approach. So we work in collaborations with other healthcare professionals. We work as a part of a team which includes gynecologists, urologists, psychologists, and pain specialists, because it could be maybe a childhood trauma which is causing pain. It could be endometriosis causing pain. It could be post-delivery they've had a big tears, and when the pelvic floor healed up, it healed up with a lot of scarring, and that's caused pain. Or they've had instance where they were in a very stressful condition, and or they've had a loss in their family, and taking stress over a period of time has resulted in this pain. So a collaborative approach ensures comprehensive treatment and improves the quality of care for patients with pelvic pain. I'll go through a case study. Do I have enough time?
Yes, you do.
So, so it's a 34-year-old female. She works as a teacher, and she had 2 vaginal deliveries, and the second one was complicated with a perineal tear and prolonged recovery. So she presented with chronic pelvic pain, 6 on 10 average, and it flares up to 8 on 10. Worst on sitting for more than 30 minutes, intercourse, and around menstruation. So in my subjective assessment, I found that the pain was present since last 18 months postpartum. So she was 18 months postpartum, and the location was deep pelvic and lower abdominal region. Aggravating factors were sitting, sexual intercourse, periods, and stress. Relieving factors was lying down, gentle walking. Previous GP management included analgesic, but she didn't have much benefit. She was referred to a gynecologist, and she was awaiting a laparoscopy to rule out endometriosis. And my objective assessment include looking at her posture, checking for any forward tilted pelvis, increased lumbar lordosis. So when we have that forward tilted pelvis, we see that there is tension being, there's a lot of abdominal. So the pelvic tilt forward means the lower back is still under a lot of stress. So she's still maintaining that pregnancy posture. And abdominal wall, there was a scar restriction from the C-section from the first delivery. The pelvic floor assessment internal examination revealed overactivity of the levator ani and the obturator internus, poor relaxation and coordination. So she complained of pain on levator ani on palpation, localized tenderness of the right obturator internus. So the pain, so her pain was reproduced when I palpated on her obturator internus. Breathing pattern was also shallow breathing, upper chest dominant, and reduced diaphragmatic. So there was no stretch happening due to the breathing. The pelvic pain impact questionnaire showed high scores in quality of life limitation. The physiotherapy management here included education, showing her that, how all these are connected. So lifestyle modification, telling her to use a right posture, pacing, stress management. Manual therapy, a lot of manual therapy, myofascial release of a pelvic floor and the obturator internus, scar tissue mobilization of a C-section from the earlier pregnancy, and sacroiliac joint mobilization. She had a program of exercise therapy where she had diaphragmatic breathing with pelvic floor relaxation, hip mobility and core stability exercises, and gradual pelvic floor down training exercises. Along with that, she had home TENS for pain relief, vaginal dilator. So whatever we would stretch during this session, she had to maintain that stretch using vaginal dilators, and referral for psychologists for CBT pain coping. Outcomes over 12 weeks, her pain reduced from 6 to 10 to 2 to 10, occasional flare-ups, but she knew how to manage her symptoms quite well. Improved sitting tolerance for up to 2 hours, resumed pain-free intercourse, better quality of life, and independent home program for ongoing management. So she did quite well, given that she had significant pain for 18 months. So it took nearly 12 weeks to bring her pain down. And now she is on a review maybe once in 6 months, and she has a lot of home exercises. And she knows, like, whenever her symptoms are returning or if she's tightening up, how to manage them. So conclusion, key takeaway points is chronic pelvic pain is common issue with many potential, including it could be musculoskeletal, it could be nerve related, or it could be organ specific. So we could get patients come to us and they wouldn't even have a diagnosis of endometriosis. So we just narrow it down. I mean, we don't look at where the origin was, but we treat what we see in front of us. So physio plays a very important role in managing pelvic pain through techniques like pelvic floor muscle training, myofascial release, exercises, and stretch management. A multidisciplinary approach is essential to provide holistic care and improve patient outcomes. So the final thoughts of physiotherapists are essential in helping women understand their condition, reduce pain management, reduce pain, support them in leading active, fulfilling, despite having. So the pain is going to be there, but we're getting them to manage it so that, they could still do things what they like and go to work, play with their kids, and, be able to do the ADL quite well. Any questions?
Thanks, Ranyana. That was a wonderful session, an update on the role of the pelvic floor physio, because I think that's, it's very challenging for patients to try and understand how that all ties together, and especially for us as GPs with these sort of interacting conditions and helping patients navigate through on that journey. I haven't got any direct questions for you. Anybody want to put any questions for Ranyana in the Q&A? Oh, very good. So
I just want to say one last thing. If a patient presents to you with any lower abdominal, any pelvic pain, by the time they are ready to see a specialist, which could take, if it is a public system, might take few weeks, few months. And if it is even private, might take few weeks. Start up with physio just to manage their pain until a diagnosis comes through, so that they're not waiting that long. And in the meantime, they're able to manage until they get a diagnosis. Sorry to interrupt you.
I think that's fantastic. And I was going to ask about the you'll accept referrals on things like the the chronic disease plans. Although
the care plans,
rebates, the care plans, although the rebates limited, and obviously they're not going to get multiple, that's still limited to 5 visits. But I guess it's helpful for some people to start them on the journey.
Yeah. Right now, I have a question for you. So if a patient comes to see their GP with chronic pelvic pain, can they do a care plan for pelvic physiotherapy?
I think they can, because CDMs has to be a chronic condition. So any condition which is more than 3 months is classified as chronic.
Okay.
So they can get a care plan for it here.
Okay, all right. I think I had some direct questions for myself. Joe, have you seen those questions? Actually, I've typed few answers, but there was one very good question from RC, Ray C, Dr. Ray C. And that question was that that when would you consider Dynogest or drosperinon? And so as far as Dynogest is considered, Dynogest is basically Visane. So the benefit of Visane is that it is PBS listed at the moment, whereas it is restricted to patients where traditional therapy hasn't worked. So the first line and second line therapy hasn't worked, and you are looking forward to move into the third line, treatment. So that is where Visane comes in. I would say the pro or the con of starting Visane is that if you're giving this to a reproductive age woman, it is not covering or it is not addressing the contraceptive need of that woman. So that means she needs to be on some contraceptive. So we have got currently 2 contraceptives, combined contraceptives available, which contains Dynogest. One is Clara and the other one is Valley. But both of these are not PBS listed at the moment. So the patients are actually buying them on private script. So that's one thing. So like pros and cons, but it is limited, like its role at currently only Visane, we actually give to patients who have failed traditional therapies. That's one thing. The other thing is, the other part of your question was regarding drosperinon. So drosperinon is combined in a lot of pills, traditional combined oral contraceptive pills. So that is actually the first line therapy. So if you see someone who needs combined oral contraceptive pill, also have associated symptoms of PCOS, then maybe drosperinon containing combined oral contraceptive pill is a better choice. And if they can afford a private contraceptive pill and have like really pronounced endometriosis symptoms, then Clara and Valet might be a good choice for them. But Visane, they are not PBS listed. So that was one question for me. So there are a few other questions. Joe, do we have time to address them?
Yes.
All right. So there's one question. Yeah, that's very good. Here, anonymous attendee has asked that please suggest hormonal options for patients who underwent hysterectomy due to stage 4 endometriosis and still complaining of pain. Thank you. So yes, in those patients, we obviously know that stage 4 endometriosis is very difficult to excise all the lesions. So they will still have some mass lesions or disease which needs to be addressed. So those patients we need to be on, we would like to be on suppression. So Visane is a good option. Visane we can continue in these patients a long term. So this is one of the good options. If they still have associated symptoms, then we can also suggest introducing amitriptyline or duloxetine and for the pelvic floor muscles relaxation and to address the chronic pelvic pain as well. So these are the options for them, hormonal and non-hormonal. Quickly, I will answer this question as well. What are the important points you'd like to see in a referral? So that is from Julie Adrian. So you see that I would suggest that if from your perspective, if a GP has done a nice history addressing, the main symptoms the patient is suffering from, if we can organize an ultrasound for that patient and CST, that would be great. I would also look into infections if they're young, obviously pelvic infections. So STD screening would be something which we should consider in these patients. So these are the important points I would like to see in a referral. Most of our GP colleagues are quite enlightened. So if you have already recommended some hormone therapy and that's not working, I would suggest that please do an earlier referral rather than delaying it. As I suggested in my presentation, that ultrasound and can miss stage 1 and 2 disease, which basically involve peritoneal deposits, and laparoscopy is the ideal gold standard. So if a patient is not responding to the conventional treatment, ultrasound is looking normal, that is the time when a laparoscopy needs to be considered. So please do earlier referral for these patients.
And there are referral guidelines on the hospital website and links from Health Pathways Melbourne through to the various public hospitals and the referral guidelines that you need. So, if you're referring to us at Western, if we're at your referring site, then just check the guidelines before you send them in. The women's have similar guidelines, but, it's probably a good idea just to check each hospital that, you may be sending that referral to.
Yeah, excellent advice. So we have got like really good resources on Health Pathway, on the link for the GPs. Now, there is another question: how long is wait list for physio treatment in primary care? Maybe Joe or Ranjana can answer that.
So that depends. I think public, I'm not able to give you a time frame, but private, anywhere it would be 2 to 3 weeks, so not too long, depending on where you're referring on to.
And that's good to know. And then please, if you go to Pelvic Pain Foundation Victoria website and Endometriosis Australia website, you can provide this link to your patients. We have got stretches available on those forums over there, so they can actually start some stretches and pelvic floor releasing exercises at home before actually consulting the physiotherapist. So that is something good to share with them, good resource. Then there's another question for right now, I think. How many times patients need to go to physiotherapists for the management of chronic pelvic pain? Thank you.
How many times would depend on their symptoms. Normally, we say we need around 7 to 8 sessions. So first 4 once a week, and then after that fortnightly or once a month. So I would say 7 to 8 sessions altogether. And after that, they're able to, all that tightness in their pelvic floor is reduced, and then they are able to manage their symptoms by themselves. They might have a little bit of exaggeration sometimes, but 7 to 8 is by then they are pretty good, yeah.
Oh, that's good.
And I think the other thing is that unfortunately GPs can't refer directly into the public physiotherapy service at the hospital. So the patient will have to be seen in the hospital gynae clinics and then referred across.
Yes, that's one thing. There's can we take one more question, Joe?
Yeah.
So there's a question from RC. When would Marina be considered now that we have these new medication options? So yes, a very good question. Mirena is actually a progestogen and it's considered as first-line therapy. So please consider Mirena first before moving on to these newer medications which are on PBS testing now.
And if you don't insert Mirenas yourselves, hunt around and maybe find one of your GP colleagues who does. There is a Mirena clinic up at Bacchus Marsh, so we do run the service up there from Western. So yes, it is a bit far for patients to drive, but perhaps for the patients who aren't able to afford private and you think they may benefit from a Mirena, that may be an option if they're wanting contraception as well. But that would just be a direct Mirena insertion. It wouldn't be an assessment of the endometriosis.
So, but Joe, do you need an ultrasound for patients like these? Because for contraception, we don't usually ask for ultrasound. That's I'm asking out of curiosity, like, you know.
No, I think if you think that patient may have a bit of a wait getting into gynae outpatients and you think that they may benefit from a Mirena, then and they need some contraception, then that may be an option for them.
Okay, so in that case, our satellite clinic can do the Mirena, but the GP can follow them for the symptoms, and it's still escalate if they're not responding.
Yeah.
Okay, all right, good. Just to add here that now we have got higher rebates on Mirena and IUD insertion. So if you the patient maybe does not want to travel or need a gynecologist review, either public or private, they're getting more rebates, on their private visits as well for these item numbers. Okay, there's another question.
Yeah.
Can we take one more question, Joe, or we are? Okay, so the question is from anonymous attendee, is there any indication to refer a patient with suspected endo who responds well to treatment in primary care to confirm diagnosis with laparoscopy to guide later management, example fertility problems, or would you stop contraception/hormonal treatment is wishing to conceive and see what happens? It's again a very, very good question. So you see, as per the evidence, there's no clear role of surgery prior or surgery later for fertility patients. So if you have a patient who has responded really well to the traditional therapy and is trying to conceive, maybe you can actually stop the contraception, allow them 6 to 8 months, depending upon their age. So allow 6 to 8 months for them to try naturally. And if they are not falling pregnant, then refer them for fertility assessment for the workup. We always encourage trying naturally first.
And there's, is there a list of physios that specialise in pelvic floor issues? My physio is more keen on sports medicine.
If you go onto the Continence Foundation of Australia, Pelvic Floor, Continence Foundation of Australia, the special interest group physiotherapy, you'll have all the list of pelvic floor physios who provide care in your area.
So I think it's
the Continence Foundation of Australia, the physiotherapy special interest group.
Thanks, Raniana. Yes, I think it's good to know who's your pelvic floor physio in the area and who's your sports medicine or the person for knees and hips. They're often got very different interests and will be really quite distressed if they get a patient coming for pelvic floor physio. So, yeah. All right. I think that's the end of our questions. So just in conclusion, could everybody please ensure you provide us some feedback? Oh, we've lost that slide. So as we know what you found helpful, what you would like to hear for next year as we start to plan our 2026 calendar. For those GPs who are shared care providers, there's sessions coming up in September. So hopefully you have all received the flyer for that. If you haven't, then please email your myself or the Women's or the Mercy, because it may be that we don't have your correct email address if you've changed it. And then we've got some diabetes sessions in October. All right, so thank you to Samina and Ranyana for a fantastic session. It was really informative, a great update, and very topical with the new medications and the discussions of what's available out there for treating patients with endometriosis and pelvic pain. I think there's much more community awareness, and people are more likely to be coming along and asking for assistance. So you will be sent the link to the recording of the session and the resources, and please have a look at Health Pathways Melbourne for additional info. So thank you.
Thank you very much, Joe, Ranyana, and Yvonne.
Thank you,
Thanks very much.
Joe.
And thanks
Yvonne.
for everyone who attended the webinar tonight.
Thank you. Bye. Have a nice evening.